Welcome to the Chad G. Ortho OT Podcast. I'm your host, Chad Guerrero. I'm an orthopedic occupational therapist, strength and conditioning coach, sports trainer, and I hold over 40 specialty certifications in manual therapy, orthopedics, and sports medicine. On this podcast, we will discuss everything orthopedic therapy, sports medicine, and more. If you're a therapist, health and fitness professional, or someone just wanting to learn more about the orthopedic and sports medicine world, then this is a podcast for you. Let's get started. Hey everyone, welcome to the episode of the Chad G. Ortho OT Podcast. I'm your host, Chad Guerrero, and today we're going to talk about what to expect if you're thinking of having a knee replacement. All right, so a lot of times, and something that, a lot of patients come in and they didn't have any idea of really what they were expecting or what to expect and what was going to happen and how this was all going to go. And, it's all kind of confusing sometimes. You get, after you're leaving the hospital or whatever, and you get some instructions, and usually a family member or caregiver is getting those instructions because, you're medicated, and so you may not remember, everything that was said and kind of what you need to do and things to take care of at home. And if you get home health, it could be, a few days before you, see a therapist, which a lot of times they should do it. You usually start the next day. That day in the hospital or, in recovery, they get you up and then walk you around. So there's a couple of different routes that you can go, or a few different routes that you can go, because some people may get home health, some people may go inpatient therapy for a while, and then some may go straight to outpatient if they have someone to take them to outpatient therapy, which when I got out of school, back in 2005, everybody usually was going to be staying, at the hospital, maybe for a couple 10 to 14 days, just kind of give or take, had to get the knee bent to 90 degrees before you could go home in a lot of cases, and then had to be able to do some basic self-care type things as far as like your bathing and dressing and things like that. And you could go home, or you could transfer from the hospital to an inpatient skilled nursing facility, and you were there for a little while, and then maybe you transferred to outpatient. But different physicians now do it just differently. We have some that like to go, straight into home health for a couple of weeks if you can't get out and about, and then some go straight into outpatient therapy. So it just depends on the physician. So basically, what you're looking at, when you come out of surgery, it's really, I've seen, I'm going to say 4 different types of things recently, or trends. One physician that I know of immobilizes the knee, so your knee is out straight, immobilized in this big, long lower extremity immobilizer brace, and the only time that comes off is when you go to therapy, and they do things with the leg of the lower extremity or the hip and the back or whatever, the ankle, what all they're working on, and then you're going to go back into this long straight brace. That's probably the most, I don't want to say uncommon, but it's less common that you see that, but that is one. I know of one physician in particular that does that, and those do well. You don't really have to worry about those having that lag or getting behind with the ability to straighten out the knee, which we'll talk a little bit about that a little further in. But so that's one technique. Another one, and this was one that's been around for a long time. The patient is sent home with one of those CPMs, or continuous passive motion machines, where you're lying in the bed and that thing is set, and you put your leg in it, and kind of it goes back and forth and just kind of is cranked on. As much movement as possible is fine. Sometimes physicians have some little precautions on ranges of motion they don't want it to go into, but usually it's just whatever you can tolerate. And then getting into even more common, the electronic bicycle kind of situation that you have this kind of thing stuck on the outside of the leg, and that measures the range of motion, so you can see where the range of motion is and kind of track your progress with that. I know there's a physician in Shreveport, Louisiana, because I'm out of Louisiana, so there's a physician there in Shreveport that's a big fan of that and likes for you to use that 4 or 5 times a day, and those patients do really well as well. And then you have the ones that just go home and there's no bicycle, there's no anything like that. And that's probably the most common that I've seen the last few years. No continuous passive motion type stuff. It's just basically move it walk as much as you can, use the leg as much as you can, that kind of a thing. So that's kind of what you're looking at when you're discharged. Those are the different approaches that physicians will use. Now, you're going to be using a walker in most cases. You're going to be on a rolling walker or something like that. For a few days, some people a few weeks. It just depends. The biggest thing is you have to have that return of motor control and strength of the thigh muscle, also known as the quad or the quadricep, because you want to make sure we have that nice and it's not going to be strong, but stronger and a little more stable, and your balance, a little more confident with your balance and ability to hold your weight, because I don't want you to fall. And then obviously things like the hamstring is important, the calf, the tib anterior, all these other muscles in the leg. But you're going to be on a walker. Initially, when you come to therapy, a lot of people are pretty apprehensive. I get it. You're nervous. You don't know, are they going to shovel my leg? Are they not going to shovel my leg? Because they got to keep it bending and moving, because you don't want to have scar tissue build up. And so a lot of times you come in, provided that you're able to have like electrical stim, like an NMES, neuromuscle, muscle electrical stimulator, using like Russian E-stim or biphasic E-stim, those types of things to put on the quad, to kind of jumpstart things and start to have you move when the machine is kicking off and on, kind of stimulating the muscles. Think about it like jumper cables in the muscle. And then maybe biofeedback is very, very effective. You can put that biofeedback where you don't feel anything, but you're looking at a screen or a tablet, and there's some electrodes that are on there. And so you see, you're looking at that, and you can kind of gauge, what kind of contraction that you're having. So you use that. So that's another, kind of another trick that's used, is using the biofeedback on the quad or the hamstring. You can put it wherever, but that's the most common places that's put to try to get things jump started. And then, as far as like range of motion, things like that, you don't have to get super crazy with it, but you want to make sure that we don't get any scar tissue build up, right? So we start range of motion, passive range of motion movements where we're passively moving the knee, or your therapist is passively moving the knee into extension, straightening it out, and then also bending it, going underneath you, as well as also doing or having stretches, passive stretches, joint mobilizations, like maybe not necessarily like of the femoral joint with where it joins with the tibia, but like the kneecap itself. So patella mobs, to try to reduce any scarring that may occur in there. So you'll do those, and then do some active exercises like quad sets and straight leg raises, or active assisted straight leg raises. You're not going to be able to do a full straight leg raise, and the physician may have a protocol against that where they don't want that done until on down the road. But you're going to do some active movements and things like that. So just easy stuff, but just mainly getting the mobility going and trying to activate the thigh, the hamstring, really all the muscles in the leg as fast as possible, to get them back, kind of kick back in to gear. To start going, again, focusing on walking, precautions, going over precautions, both with your mobility, just walking around in general, and transferring, getting up and down out of the chairs, and maybe getting in and out of the car, bath, shower, bath, those kind of things, which if you were inpatient, then they probably have already went over a lot of that stuff with you. And so, you may get, in other words, that may have already occurred, and so when you go to outpatient, you're kind of past a lot of that. Now we're just advancing some things. So, and a lot of this I'm talking about just that basic, start with the electric stim and some of the movements and things like that you're going to do. That's really more like right after the knee replacement. Not saying you still wouldn't have those things done, even if you come like after you had, home health or whatever first. But, I'm just kind of speaking just directly afterwards. Some of the things that you're going to notice is obviously going to be swelling, pain, swelling, tenderness, not just around the knee, but you may also notice that down around the ankle area, on the shin. Sometimes that's just from handling or how your leg may or may not have been strapped in to stabilize. So that's all normal. Some redness is normal. Obviously, the disclaimer on this is always follow the instructions of your physician or your discharge facility or your therapist, etc. Because anything I talk about in this podcast does not replace in-person medical advice. But You want to, some of the redness and all that is normal. Some of the discharge may be normal as well around your replacement, the incision site. Some people may have a bandage that's going to be left on for, maybe anywhere from 10 days to 14 days. I've seen it at different lengths of time. So that may be on there where the physician doesn't want that removed. You may also, or it may be a situation where whenever you go to therapy, the therapist changes the bandages and all that, and, right then. And so I've seen it both ways. It just depends on the physician. If you're used to, if your therapist obviously has worked with your physician a lot, they kind of know what they like and how they like things done. So they're going to go by that route. But a lot of times they'll change the dressing out. It is not uncommon also for the foot to want to turn outwards whenever you're walking. That's called out-toeing. So you may notice that. That's normal. Anytime you have a knee surgery, especially of really any kind, you're going to notice that foot wants to turn out. So correcting that is something the therapist will go over you with, and that's just take a little time. Also, having a good heel strike when you're walking so that your heel hits first and you push off your toe. That's all things that will be encouraged by your therapist. And as you increase your ability to straighten out your knee, that heel strike ability where the heel hits, that will get better as well. And that's why it's so important to be able to get the knee straight or flat. If you're lying on your back, getting it flat. So that will happen. Any popping or clicking that you may notice over time, it may not be doing it initially. It may do it eventually. That's all normal stuff in most cases as well. That's just kind of everything just settling a little bit and kind of adjusting. Just, your body kind of acclimating to everything. So some of that is normal as well. And the swelling is going to vary. Like you're going to have some, initially, obviously there's some swelling, then it may go down. But then the more that you start doing, the more that you're on your leg and putting pressure through the knee and using the knee, you may notice more swelling. And so you may lose some of the range of motion. So don't get discouraged. Maybe yesterday you had 115 degrees of flexion where you're able to bend the foot, back like you're going to kind of kick yourself in your butt. And then maybe today it's only 100 degrees. So because of some of that excessive swelling that you've had because you're walking and you're doing more, it may not always stay, right there at that 115 or 120 or whatever that number is, wherever you are. So don't be alarmed by that. That's normal for it to kind of fluctuate and go up and down. Now, obviously, if you have in the calf area behind the knee, if you have an area that becomes very warm to touch, it's red, maybe has a red line or a streak, you push on it and it's very, very painful. That could be a sign of a blood clot. So you definitely want to have that checked out. There's a test for that you can do, or your therapist may do the Homan's sign or Homan's test. They may do, and then, but you need to have things like a Doppler or something like that done to try to rule out a possible blood clot. So I have had a couple of patients over the years have blood clots. It's not very common, but and that I've seen, but it can happen. And a lot of times you're wearing those compression garments or TED hoses. You want to wear those just like your physician recommends. It's important that helps to reduce the chances of developing blood clots. And so anyway, and you may also notice some numbness on the outside of your knee, and that's normal. That may stay like that for a while. I had people for years that stayed numb like that, and that's okay. So it's not a huge deal. So you may notice some of that. You may also notice on the outside of the knee, running up to your hip, you may end up having some pain. A lot of times that's your iliotibial band or IT band where that inserts in the knee, and that's from some of the muscles in the hip, the TFL muscle, parts of the glute muscle can become tight and spasm due to compensation, what's called a whip, a movement of your leg, even subconsciously you're not realizing you're doing it. So that may start to happen. You may develop some of that. That's all treatable stuff. Your therapist will be aware of that and just let them know, and then they'll kind of work on that area and go through some things to try to mitigate that and make that better. So that's not uncommon as well. Range of motion wise, again, we want the knee to go flat. And let's say that you're female. And I say female because a lot of times females are a little more hypermobile. And let's say that your unaffected knee or your non-surgical knee has maybe 10 degrees of hyperextension. It kind of bends backwards the other way. It's not just getting to zero. So then on the surgical knee, I would like for the surgical knee to get as close to the non-surgical knee as possible. So just stopping at zero may not necessarily be ideal. If you can get a few degrees of hyperextension to make them match as much as you can, that evens things out, and it reduces your chances of having some sort of compensation whenever you walk and things like that. But if you can't get the knee flat, this is probably the biggest worry. Is if you get to a point where you can't get the knee flat. It's normal at first for it may not to go flat. You may be lacking 20 degrees from it going all the way flat. Some cases I've seen 30 degrees, but I like to see 20 degrees or less when you come in. If it gets to that point where you can't get it flat, then that can cause some problems. And once you're behind on that, that's very difficult to regain that. So you definitely want to make sure that you are doing a lot of stretching to get it flat. And the big tip with this is don't put anything behind the knee. Like, don't roll up a towel or a pillow and prop it up behind your knee. I know that feels better. You are better off to float the knee. So basically put your pillow or your towel or whatever you're going to put underneath the calf area so that the back of the knee is not touching anything. And it's just kind of floating there. And just like gravity and the weight of the leg itself, just kind of pull that down and straighten that out. Because by putting something behind the knee, you're encouraging that what's called flexion contracture to happen, and that's going to be a real issue because a muscle back behind there called a popliteus muscle, it helps to flex the knee, to bend the knee back underneath or bring your foot towards your butt, but it also helps to unlock the knee when the knee is out straight. So there's a little bit of rotation that has to occur going from like an externally rotated knee a little bit, the tibia is a little externally rotated, to a little internal rotation, just unlocking. So you definitely do not want to put something behind the knee. I mean, if it's just killing you and it's just throbbing, hurting, and you've got your ice on, which that's another thing about the ice, and you want to put something behind there for a little bit. I mean, a little bit I guess wouldn't hurt, but if you can avoid it, try not to put anything behind it. And that's the other thing. Definitely use your ice machine. A lot of people get those polar ice or some sort of ice machine, ice packs, frozen peas, whatever you got. Definitely keep icing. Even whenever it feels like it's not really hurting that much, even when you're going to therapy and you go home, still ice it every day. Just still try to control some of that swelling because even though everything may be healed or close to being healed, the brain's still sending a ton of fluid there, so you definitely want to try to mitigate that and try to reduce as much swelling as you can. So keep using your ice. I also tell people something that's really good to do is like sit in a rocking chair or sit on a swing on your porch, or one of those glider chairs, anything where you can put your foot down and then move your knee into that flexion position is great to do. I mean, it's in most cases it's not going to hurt a thing in the world. The more that you do, the better it is, really, within reason. So that's just kind of what you're looking at. And like I said, you'll start initially on a walker, and then you'll come off of that. Maybe you go to a cane, or maybe you go from the walker to nothing. That's just therapist and physician discretion on that. And but the more that you use it, theoretically, the better it's going to do. And for a lot of people, something that I really encourage you to do is to go to therapy. Definitely finish your therapy visits. When you get done with therapy, continue your exercises, movement at home. Don't go to therapy for 2 or 3 months or whatever it is. And every patient's different. Some patients like 4 weeks and you're good to go. It just depends on where your range of motion is. But definitely, when you're done, don't just I'm going to stop doing the movements and exercises and just walk around. That'll be good. Keep doing your exercises that you can do at home, safely with whatever equipment that you have. And you don't always have to have equipment, but whatever you can do. Make sure before you discharge that you go over with your therapist, all the things that you can do at home to continue, taking care of this, to make sure that you don't backslide. Because I can assure you, I've seen a lot of people in almost 20 years that, they end up not having all the mobility they should have, or the leg has been weak and it regressed and it hurts again, and just not a successful outcome post surgically. So and the surgeons are really good at the techniques and all that they do now, and how they go about this, and you can get a lot of use out of a knee replacement. It's not like I'm gonna get a knee replacement in like 5 years. I'm gonna have to have another one. No, they're really pretty good, and they last a good while, as long as everything is done, not just surgically correct, but then everything is done correctly with your therapy. It's super, super important, that you find a therapist that's going to be really good at taking care of that. Because it's if you go somewhere for therapy and then in and out like a 20-minute deal or 30-minute deal, and you pretty much just kind of did all your exercises yourself or whatever, I definitely find somewhere else to go, because not everybody just, I don't know, has the same drive or is created equal, I guess you'd say, as far as therapy, skills or whatever. So you want to make sure that you find somewhere that's really going to spend some time and work through all the questions and problems that you have. So I hope that helps everyone. If you have any questions with this, you can email me at chadgorthoot@gmail.com. You can also go over to my website, and you can click on there. There's different ways to contact me on there: TikTok, Instagram, Messenger. There's all these different things. You can click on that and reach me. Last side tidbit on this: there is a really, really neat, if you're a clinician and you're having trouble, getting your patient to get that last bit of extension, that terminal extension of the knee, Edge Mobility Systems, which is owned by Dr. Urson Religioso, a therapist and a friend of mine. If you go to my website, go to the very bottom down there, and there is a link for Edge Mobility affiliate. If you will click on that, it will take you to his site, and one of his sites, and there is something called the Knee Terminator, which is really, really good. It uses a cuff weight, and it is a good way to use a low load, long duration stretch on the knee to try to get that last bit of, extensor range of motion. So thanks so much for listening, guys. I hope that you will listen again. Please rate me 5 stars wherever you listen to this podcast, and you guys have an awesome day. This podcast is brought to you by Guerrero Rehabilitation, setting the bar for rehabilitative and sports medicine care.